Hello, and welcome to Let's Talk About It. This is Taylor, your host, and I hope that you all are making your way through the week. There's a lot of things going on, so I hope that you can center yourself. I hope that you are nourishing yourself, because no matter what is going on, you are worthy of space. You are worthy of pleasure. You are worthy of experiencing joy, no matter what is happening in your life, in the world, anywhere. So welcome to the show. Thank you so much for being here. And we got to talk about some stuff before we get into today's episode, because I am very well aware that the purpose of me doing this podcast is kind of to make people a little bit uncomfortable, right? It's to talk about the things that are a little bit more taboo, to talk about the things that really challenge our way of thinking, that challenge the things that we've already been taught, that challenge the way we feel about certain things. And I'm going to let you know right off the bat here, today's episode is probably going to challenge you a little bit and might make you feel really uncomfortable. And I hope, as always, that you can enter this episode with an open mind, open ears, and an open heart. A lot might come up for you listening to this. Today, we're going to be talking about pharmaceuticals with mental health. We're going to be talking about psychiatry. We're going to talk about chemical imbalances. We're going to be talking about things that really do go against some of the things that we have been taught. And I think it is always important to question those things and be really intentional on further educating ourselves in these areas. So today, the guest that we're going to have kind of talk through all of this with us is actually someone that I met through my Ph.D. program at Modern Sex Therapy Institutes. And his name is Dr. Tom Murray. He's an international trainer, educator, and couples and sex therapist. He is widely sought after as an expert in the field of sexuality and intimate relationships. For nearly 20 years, Murray has worked with everyday folks to embrace their weirdness, shed labels and shame, and lean into anxiety and build better and stronger relationships. He has appeared in numerous venues, including Huffington Post, Daily Mail, as well as radio, television, podcasts. He really does a lot of things. And he also directs a group practice in North Carolina and holds a faculty appointment at Northwestern University's Family Institute. He is really going to challenge you here. So we will get right into it. I hope that you do whatever you need to do to take care of yourself. I definitely encourage you to check out the episode notes and check out some of the links. We're going to link some articles and some other resources for y'all to check out. And yeah, as always, open mind, open heart, open ears. And oh boy, let's talk about it. All right. Welcome, Dr. Tom, to the show. Thank you so much for being here today.
I am so excited to finally get to do this. This is something I've been looking forward to for some time.
Yes. Yeah. So I want to say it was a few months ago that I came across you, that we interacted, that I was able to learn from you in my program at Modern Sex Therapy Institutes for the Ph.D. program. And your presentation was so interesting to me that I was like, I got to talk to him some more. Like, this is like information that like I don't feel like we get often, especially throughout our education. So I like super appreciated that, you know, the way you presented was kind of stepping outside of the box a little bit. And definitely brought up some reactions in people, which is always where I think that's how you know you're hitting something.
Right.
So really, really happy and excited to kind of continue some of that conversation here. I'm wondering if you could share a little bit with folks before we get into anything, just kind of how you got like started in this field to begin with.
Well, I think it really all started in childhood. You know, any therapist, I think, usually becomes a therapist because they've had 18 years of apprenticeship growing up in their own families. And certainly that was true for me. And even at a young age, I was aware that people just felt comfortable talking to me about their sex lives. You know, now as an adult, I can look back and see those conversations were pretty inappropriate, but
lack of boundaries.
It gave me a clue, and I was sharing a story with a biology professor and sharing with him that people just naturally felt comfortable talking to me about their sex lives. And he said, that's a gift. You should really pursue that. And so fast forward, I got my master's and doctorate in couple and family therapy from the University of Florida, and then eventually pursued the ASEC sex therapy certification.
Mm-hmm. Yeah. Which is like a real certification. That is like, there's a lot involved.
There is a lot. Yeah. ASEC is definitely the premier organization for sexual health professionals. And they take it very serious as a sex therapy supervisor as well. And I'm, helping people to get through the process. It is very extensive and, rightfully so. People want to feel like they can trust their providers to understand what their sexual health needs are. And I think ASEC certainly does that.
Yeah, definitely. Well, and especially considering the amount of sexual shame that we experience throughout our culture and our conditioning in society, I think it's extra important that as providers, we make sure that we've checked ourselves on all of that shit so that we are not continuing to further that harm.
I'm so glad you mentioned that, because I think we as a profession often think oppression happens to our clients out there and don't really consider how they might be oppressive in their own approaches. Because, we like to think that we're always caring individuals, but in fact, for a lot of us, how we treat our patients, we treat them with our own set of biases that can certainly foster more shame.
Yeah. Are there any biases that you've maybe recently or maybe at the beginning of doing this work that you've had to do some intentional work on kind of unpacking?
Oh, for sure. Like many therapists, when you ask therapists who are the people they would least want to work with, substance abusers are high among those for a lot of people, and also sex offenders. And I have, since becoming a sex therapist, have created a little more of a niche as a forensic sexologist and began to work with people who've been incarcerated for sexual offenses. And, a lot of these people really do need help and are really remorseful about what they've done. But it also opened my eyes to the injustices even within that area of work where, it may have been that 18-year-old who had a sexual relationship with a 16-year-old and the parents found out and that 18-year-old got in trouble and now is on the registry for 10, maybe 30 years. I mean, it's just, it's much more nuanced than what a lot of people may think. So that's, it has certainly been an area of my own profession where I've modified my beliefs.
Yeah. Mine was with eating disorders.
Oh, how so?
Was coming out of school. I was like, well, there were two coming out of my bachelor's. The first was eating disorders, and the second was working with schizophrenia. Both of those really scared me. And I felt like I would not be equipped for that. And, I have a really huge discomfort and fear around throwing up. And for me, I was like, working with that population, I think that would just bring up so much discomfort for me. And also the fact that I am like a thin-bodied person who meets a lot of the societal standards of beauty, that I would just trigger a lot, and that maybe I would not be the best therapist fit for that population. And schizophrenia, I just thought was just so over my head and would be just scary. And my first job out of my bachelor's was doing in-home visits with clients who had bipolar and schizophrenia diagnoses. And I remembered when I did the interview, they did not specify that it would be clients with schizophrenia. And it was like on my first day, I was going through my client caseload and of what the diagnosis were. And I was like, oh my God. I was so scared, and ended up working well with them. And then my first client in my internship in graduate school was an eating disorder client. And she was one of my favorite clients that I've ever worked with. And we did great work together. And I was like, oh, that was really good to like challenge myself in that area. But yeah, it is interesting how we pick those things.
And, I think about it in terms of too, how, we're, as mental health clinicians, we're first citizens of our culture, and so we're influenced by the messages out there, and particularly these more severe what we call severe diagnoses like anorexia, for example, or schizophrenia. We're immediately associating them with medical interventions. They require medical interventions, and unless you're someone who's trained in medicine, you're naturally going to feel like, oh, is this really an area that I can be helpful? But of course, mental health wasn't always focused on the biomedical model. For decades, people were getting wonderful treatment with talk therapy, including with schizophrenia and eating disorder. Now, again, there may be times where medical intervention is necessary, but I think that how we frame the condition, and if we frame it as something that is foreign to a lot of people, when we talk about the bioamine theory or serotonin, norepinephrine, dopamine, a lot of people's eyes just glaze over and they're like, I don't understand that. That's all Greek to me. And so we think, someone with much more education, different education, they're the only ones that can be helpful, when in fact people are suffering. And what's most powerful is that therapeutic presence and that willingness to be able to sit with a client in that space that they're inhabiting, trying to make sense of their own world and navigate it the best they can.
Yeah, totally. Well, and I think to that point, there's this sort of like elitism or classism that's involved, I think, with how we are taught about, different disorders, right? And this really medical, clinical approach to working with folks. And I mean, I want us to get into this a little bit here, because I think for me now, working as a therapist, I really just look at this as like, this is another person who is struggling and going through some shit. And the best thing I can do here is to hold space for them. Right. It doesn't matter, honestly, in my opinion, if I have a doctorate in medicine or if I have the highest level of education and what it is that they are suffering with at the time, because ultimately it does come down, in my opinion, to human connection, feeling seen, feeling held, feeling heard, that those things really do go such a long way. And I think we are often so quick to try to throw a medication, throw a action item at it, throw some kind of thing that we think is just gonna bloop. Well, we're doing our job. We're gonna fix it like this.
Mm-hmm. It's so true, and depending on how people are paying for services, if they're on Medicaid or Medi-Cal or using insurance, that payer source really says that as well. When I like to think of the DSM, or the Bible of mental disorders, as really the Baskin Robbins of unhappiness. And the book just has many flavors, and basically we're just trying to find which page your flavor is on. Right? And then we slap in a code, anxiety, depression, etc. And but it's really just unhappiness. It's many manifestations of unhappiness, and trauma. Most of that comes from not having a witness to one's life, right? And a therapist is, you talked about it, is to, being able to hold space is in essence also saying, I'm going to be a witness to your life, right?
Yeah. Yeah. Well, and I'm wondering if you can share a little bit, how we met, you were presenting essentially on like the pharmaceutical industry and psychiatry and how that impacts our sex lives, how we can work with clients with keeping informed consent with medication in mind. And so I'm wondering if kind of before we get more specifically into that, if you can share some of what your either professional or personal, whatever you're comfortable with, experience in kind of going about that, like the relationship between this kind of, in my opinion, quick fix to using medication for things related to our sex lives or our mental health, and that relationship kind of with the pharmaceutical industry.
Yeah, so like a lot of therapists, I was trained that medication is an important intervention. And, this would have been the late 90s, which was the decade of the brain. Bush 1 called the 90s the decade of the brain. And a lot of money was being poured into neuroscience in order to help better understand mental disorders. And so by the time I graduated my master's degree, I worked in a skilled nursing facility. And I was the chair of the psychopharmacology committee. In other words, when your grandma was in the nursing home, I was the one making the case of let's get them on antipsychotics usually. And so after I got my Ph.D., I attended a conference with William Glasser. And William Glasser was a very famous psychiatrist within the field who had developed what's called reality therapy or choice theory. And he wrote a book called Warning, Psychiatry Can Be Hazardous to Your Mental Health. And I remember sitting in the audience, this was at the American Counseling Association, sitting at in the audience of that conference and trying to argue against these points that he was making, right? And I found that I couldn't argue against them, and that really piqued my interest. So I read his book and was caught up in reading just so many other authors who had this critique of psychiatry or psychiatric medicine that was never exposed to me in graduate school. So I spent several years after getting my doctorate really unlearning what I had been taught and discovering that there were a significant number of medical professionals as well as non-medical professionals making the case that these medications, the assumptions upon which these medications are being prescribed is quite quite a smokescreen, that there isn't the certainty that I think a lot of people think that there is when they're being prescribed these medications, namely being told that the reason they need this medication is because they have a chemical imbalance. When in fact, I have never, Taylor, met anybody who has ever had their chemicals measured. And yet they're told they have a chemical imbalance. Whereas if you were told you had diabetes, you would have your blood sugar measured, and then you would be given insulin, and you would have your blood sugar measured again to see if the insulin is working. You would have some concrete data to be drawing conclusions from. And so we also began to realize that these medications had significant side effects. So when I was telling telling people to get their grandma put on Risperdal, for example, only later did the research demonstrate that antipsychotics in the elderly expedited death, right? And in 2009, I think it was Nancy Andreessen, a famous research psychiatrist, her study came out where she found that for every year someone was prescribed an antipsychotic, their brain volume decreased 1%. And so when, 1%, if you're taking antipsychotics for a year, a 1% reduction in brain volume isn't likely to be all that significant. But when you think about some of these people are on these medications for 10, 15, 20 years, a 20% reduction in brain volume will account for most of the cognitive decline that we see among people who have been diagnosed with schizophrenia. But we think, oh, that's the disease, when in fact it's actually an iatrogenic effect of the medication that they've been prescribed. And so my thinking has really just shifted dramatically over the course of the years, where I've been really pro-medication to at one point being quite anti-medication. And then later really focused on that idea of social justice and informed consent, that, you know, people, if they understand that these medications have these benefits as well as these side effects, and they still opt to take the medication, well, I think that that's certainly within that person's right to take advantage of what's available to them.
Yeah. You've been on quite a journey there, sir.
Yeah, it's been a crazy one at times, for sure. I mean, I haven't made a lot of friends, as you can imagine. People.
Well, the reflection of sitting at that conference and trying to come up with an argument to everything that he was saying, I think is a lot of what my classmates were experiencing when you were presenting. And I'm sure perhaps some folks listening to the podcast right now as well. And it's interesting to me that is usually our first thing when something sounds new or sounds like it goes against what we know, instead of opening our hearts, minds, and ears to trying to understand it. More so, it feels so uncomfortable and scary that I just want to say, well, no, actually, that's not true because this, and that, or let me figure out how that's not true. And, you know, the chemical imbalance piece that you're talking about here was, I think I did post this on my Instagram, and people very mixed feelings on this. And I think we try to find comfort in the things that don't make us feel good, and the things that scare us, and the things that cause us pain. And that there's a lot of, I think, how the medical field has impacted the field of mental health that helps us feel like we know what we're doing. Right. Or like we can figure it out. This is going to fix these things. It's like it's been a little bit of like this crutch that at times we use, like you said, with informed consent, and it's very understood, and there's proper boundaries and proper education around it. And a lot of the times it can feel a bit dismissive. I even think, reflecting back on my own education, starting off, a lot of the ways that I was taught about different disorders still carried a lot of that stigma. And so like you said, unlearning a lot of that stuff, even after your schooling, I'm sure that it was hard to make friends at times because you're going against a lot of the things that we're taught are just so like normal.
Right. I'm so glad too that you brought up that idea of stigma, because a lot of people think that, what we need to do is make the parallel or similarity between mental illness and medical conditions, you know, like taking antidepressant for depression is like taking insulin to diabetes. And while on the surface that makes some sense, the research is finding that the biomedical model for mental health has actually contributed to stigma, because when someone doesn't take an insulin, it's obviously going to have harsh effects. But the idea is with mental health that the brain is somehow diseased. And when you don't take a drug that addresses the diseased brain, well, now you're dangerous and unpredictable. Right. But diabetes doesn't have that same effect on personality as we think that mental illness has an effect on personality when you're using that disease model. And so that it push to make it about this diseased brain is increased stigma. There's no evidence that it actually has made people more compassionate towards people with emotional problems or what we call mental disorders.
Yeah. So I'm wondering if you can speak a little bit more to chemical imbalance, because I think this is a piece that folks really like to hold on to, that helps us make sense of ourselves, that helps us try to have compassion for others, right? Understanding, well, it's not them. It's not about, their healing or putting in that work. It's about that this is just something that they are stuck with for the rest of their lives, that they have no kind of control or agency over. And wondering if you can speak a little bit more to maybe what the research says around folks for or against having a chemical imbalance.
Yeah. So, just to speak at it, globally, your brain chemistry is constantly in flux because your relationship with your environment is constantly in flux. And so we want a brain chemistry. Of course, by the way, within mental health, there are the soups, what were called the soups and the sparks. Right. The soups are those people who are all about the brain chemistry. The sparks are team electrical exchanges between neurons, right? And so even within the profession right now, you have more of the transcranial magnetic stimulation folks, the TMS chairs. I don't know if you're familiar with those, where you go to your psychiatry office and they put on a cap and they have these electrodes, if you will, surrounding their head, and they stimulate different parts of the brain using these magnetics. So that group is still alive and well and doing their service. When it comes to the soups, though, there was this observation, I think, since the 50s, where they would design medications to serve other purposes. And when they would study these effects on these patients, the patients would report changes in their mental status. Maybe they felt better, right? They felt less depressed. And so they looked at, well, what effect does this medication have on brain chemistry? Well, these medications, such as selective serotonin reuptake inhibitors, the medications prevented the reuptake of the serotonin. So therefore, the person must have a deficit in serotonin, right? But that is called exjuvantibus reasoning. So let me give you another example.
That's a big word.
Yes. I'm holding in my hand a big cup of caffeinated coffee, and I love to drink coffee. I drink it all day long because it gives me the feeling that I want and that I imagine everyone else has, which is just alert and oriented, ready to go.
Yeah.
So it makes me feel the way I want to feel because it has a particular drug called caffeine, right? But it doesn't make me feel the way I want to feel because I have an underlying caffeine deficiency, right? And that is the assumption that people make, is that, and it's a logical assumption, that if I have a chemical problem, it makes sense that I would use a chemical to fix it, or that I have some kind of chemical imbalance, and that because this medication makes me feel more the way I want to feel, that must mean that my chemicals are somehow being balanced. When in fact, the chemicals are, the medication cause a chemical imbalance, and that's what you want. That gives you that feeling of, I don't give a shit anymore. Like if someone is in a domestic violent relationship and they're depressed, and they come to their psychiatrist for an antidepressant, and that antidepressant makes them feel like they don't give a shit anymore, right? They're less depressed about their life situation. Well, it just is that maybe how they want to feel. They want to be numbed out, right? Because their life is so shitty, but it's not because it's correcting something in the brain. One of my favorite quotes is that if someone comes in and is depressed, the first question a provider should ask is, are you surrounded by assholes? Right? Because it's our context that has way more to do with our mental well-being than chemical and electrical exchanges in between our ears.
Yeah. Well, and I think that in part it also just goes to like the quickness of diagnosis and the emphasis on the medical model and the really like clinical approach, and also insurance, what they require, right? That someone who is in a domestically violent relationship might come in and we're quick to slap on a diagnosis of depression. Well, this person's experiencing abuse. They're experiencing trauma. Of course they're going to feel however it is that they're actually feeling. That's valid because look at what they're going through. That makes a lot of sense. While it's not, in my opinion, at least when I'm working with folks, I'm not like, oh yeah, well, you know what? I think you have this depressive disorder. I'm like, oh, it sounds like you are experiencing abuse. And of course you are feeling stressed and not your best self. So that makes sense to me. One of the things that you brought up in your presentation, which was honestly something I had never heard before, was about where serotonin is located in our body. Could you share a bit on that?
Yeah, so we often think of serotonin, well, all the biomeans, we think of, oh, they're just chemicals that just occur in our brain. But in fact, 95% of the serotonin in your body is outside of your brain, and most of it is connected to your gastrointestinal tract. And that's one of the reasons why so many people, when they take an SSRI, for example, experience GI problems, right? Because the medication doesn't know, oh, I should only be focusing on dysfunctional neurons in your head. It's pervasive in its distribution throughout the body. And if there are receptor sites for serotonin, as there are in your GI tract, then it's going to impact your gastrointestinal system.
Yeah. And I mean, this is the perhaps inner hippie in me. This is perhaps like gonna transition to a little like woo-woo-wee stuff. Where I think that a lot of mental illness makes a lot of money. And when we look at actually taking a holistic approach here, when we think about the fact that, like you said, like 95% of our serotonin is located in our gut, and how do we treat our gut? How are we caring for our gut? Just, yeah, it doesn't make a lot of actual sense, but like it makes a lot of dollars.
It's true. We when you think about therapy and you're spending 45, 50 minutes with a client, whereas a prescriber, they can see a patient for 10 minutes and then prescribe and get out the door. Prescribers certainly generally make more money than non-prescribers, but from the insurance company, they're just wanting to get people better. And so whatever method they think is going to get people better faster, they're going to support those approaches. But there is zero evidence. There is no evidence. And we're talking 50 years of data. There is no evidence that psychiatry is any more effective in treating mental illness than non-prescribers. In fact, during the 90s, there was a study by the NIMH, National Institute of Mental Health, on depression, and they found that the least effective psychiatrist prescribing the active ingredient was still less effective than the most effective psychiatrist prescribing the sugar pill. So in other words, the sugar pill psychiatrist was still more effective than the least effective psychiatrist prescribing the drug. And that's part going back to where we started here, the quality of that relationship is so important, right? To be seen. So many of us go through life where we just don't feel seen, or experiencing trauma in early childhood, or certainly in adulthood. When we experience trauma and we are alone in the experience, then it becomes frozen in our psyche, and we're not able to integrate those experiences.
Yeah. Well, and like the whole psychiatry has always just felt like something that's like way up over there to me, that I've really never wanted to have anything to do with. And it just never made sense to me that you're spending 10 to 15 minutes with this person who is then supposed to give you this magical pill to where then you will meet up once a month, where I'm like, how the fuck does that make sense when that is going to have such an impact on your body, on your mind, on your day to day? And you touch base with this person once a month for 10, 15 minutes. And I remember, learning like the best approach is to be doing both psychotherapy and psychiatry, that if you are seeing a psychiatrist, that absolutely you will have better experiences and outcomes with your mental health treatment if you are simultaneously doing talk therapy. And to me, that just kind of spoke to like, well, yeah, because people need to be held in relationship. Like, obviously, just doing psychiatry alone, 10 minutes once a month doesn't make sense to me. At all.
And, in our business, A Path to Wellness, we have my co-owner is a psychiatric nurse practitioner, and we have another psychiatric nurse practitioner. And what I love about psychiatric nurse practitioners is that they tend to be very whole person centric. And so an intake with one of our providers is well over an hour to look at all the facets of that person's life and look at where interventions can occur, such as diet, exercise, a meditation or prayer practice, community involvement. And certainly, there are a number of medical issues that can impact mental health. For example, we talked about eating disorders earlier. Psychiatry can be immensely helpful in treating eating disorder, particularly anorexia, where there are medical conditions that can impact, that can be the co-occurring. And having a medical professional who's much more familiar with that than I am can be instrumental. So, certainly I don't want to make it sound like psychiatry is the devil. It really is not. And, I have a faculty appointment in the Department of Psychiatry at Wake Forest Medical School, and training psychiatrists, fellows there. These are very caring people, the people who really want to help, and people who lament the impact of insurance companies on the care that they want to provide. So it's in that article that I wrote years ago, in which I don't know if I spoke about this in much detail in a presentation that I gave for the Modern Sex Therapy Institute, but I drew a parallel between the mental health industry and cults. And that there are a lot
I do not think you went into that, but I'm ready for it. I am ready for it. I don't think other people were ready for it, but let's go there. That was one that probably made me a little more enemies. But to think about how we indoctrinate people within the mental health industry, one of the core examples of a cult, right, is that the inductee is to become exclusively reliant on the leader. And in many ways that happens within psychiatry, right? There's this expectation that, the psychiatrist or the prescriber or the mental health clinician, doesn't have to be a psychiatrist,
that person has the expert knowledge, and only they have the expert knowledge to help that person along in their journey. And that in psychiatry, for example, people are told, yeah, you can never get off of your medication. Do you want to be a burden on your family? Do you want, et cetera, in ways that are very similar to cults. And I outlined a lot of other parallels between the mental health industry and cults. So people are if they are interested, they can Google my name, or we can put it in the show notes.
Yeah, definitely send it to me, and we'll put it in the show notes here, because I feel like one of the first things that I learned about going into this field was that one of the values of being a psychotherapist is to empower our clients and to not create a sense of dependency. And I do think when we have a very medical, clinical perspective here, it can make folks feel like they need these professionals, this medication, whatever it is, in their life 100% of the time, and that in order to take care of themselves, this is like absolutely necessary. And I don't think at all points in your life it is absolutely necessary. And, I was talking about this with my supervisor probably like 6 months ago about how this is like one of the weird jobs to have, where it's like, my job is to make it so that like, hopefully you don't have to pay me anymore. Right. Like, I want to empower you to have the skills, the tools, the confidence, the capability, the resiliency to be able to move through your life and not necessarily feel like you need to have this relationship. And I think that is a piece that people definitely miss here. There is so much more I want to get into with you here. Like so many other things that I'm sure folks listening have like a ton of questions too. One thing I want to make sure that we touch on here before we have to wrap up is the notion of informed consent when it comes to taking psychiatric medication, especially for those who are struggling with sexual health situations. And I think, one of the points that you brought up in your presentation was just like how we treat clients when they talk about medication, that oftentimes we can tend to be very dismissive of like, oh, they're just complaining, they don't want to take it, because, they're having a hard time getting wet for sex. So now they think that they just don't need to take their medication anymore. It's just like, well, that's just a side effect. That's just what you're going to get. And kind of this like deal with it mentality. So I'm wondering if you could just give folks a little piece of information here on maybe how they can best go about receiving informed consent from their providers. And then maybe also how like providers can help practice better informed consent around some of these side effects.
Yeah, what I would say is that no one's going to take your mental health as seriously as you will. Mm-hmm. And so being almost exclusively reliant on your prescriber to give you the information you need maybe foolhardy only in that their knowledge is based on whoever's funneling information to them, right? Mm-hmm. And so taking on that responsibility means getting exposed to other alternative views, but also credible views. One of the I think the best resource available to people is madinamerica.com, which is kind of like a Huffington Post of mental health, and really great articles out there on this alternative view that's based still within modern science. A lot of these contributors are researchers themselves. So getting exposed to those alternative viewpoints. I would also encourage people to read resources from people with lived experience, not with people just with letters after their name. But if you have bipolar disorder, well, read from people who recovered from their bipolar disorder. Don't just assume that because your prescriber has said you're going to need to take this medication for the rest of your life. That to me is false hopelessness. And we need to be more worried about false hopelessness than we are worried about false hope.
Yeah.
So, there are people out there who certainly have recovered from schizophrenia, recover from bipolar disorder, et cetera. And so it's getting that kind of exposure. And then from the prescriber end, again, getting involved in the professional organizations such as ethical psychiatry and psychology, or critical psychiatry. There are a number of organizations out there that are wanting to provide that alternative voice, so that when patients are coming in distress, that you're giving them the information that they need in order to make an informed choice. That taking for example, I take anti-anxiety medication. I have this odd thing where I wake up in the middle of the night with an anxiety attack. I don't know why. I have no worrisome thoughts, but I just have this, anxiety. And so depending on the time that it happens, I'll take a Klonopin and then fall back asleep. But I don't take it under the belief that I have some chemical imbalance. I take it under the knowledge that that the medication has a side effect profile of which some of the side effects I want, which is that effect on my GABA system, and therefore I feel less anxious. Or back in February, I did a month of Wellbutrin for a non-depression related condition, and I saw some benefit, but not enough would make me continue to take it. So there are reasons to take the medication, but what I'm encouraging is that people take them based on informed consent and not being exclusively reliant on the prescriber to provide them with that knowledge.
Mm-hmm. Just from that, I'm like, I have 1,000 other questions and things. I'm like, I feel like I could talk to you forever on this stuff. And
that includes, I should mention, because I didn't talk about the sex there, so many professionals are so uncomfortable talking about sex with their patients. And so if you are having sexual side effects, which are extremely common with these medications, find a prescriber who is willing to have those conversations, or find an advocate such as Taylor or myself who is comfortable talking about sexual issues so that your voice can be heard.
Mm-hmm. Yeah. Well, yeah, I mean, I think especially within the sex experience that folks feel really torn between prioritizing my mental health and I need to take this medication, but it's also having these really negative impacts on my sexual health. And that plays a huge part in my mental health for most people, right?
Yeah.
So it's I think people end up feeling really stuck of oh, am I just going to say fuck science and fuck what these professionals are saying is good for my mental health because I want to have sex? And part of me is kind of well, maybe. I'm not your doctor and I'm not a medical professional, but maybe, I don't know.
Yeah. Again, sex is a significant source of meaning for a lot of people. Mm-hmm. And when they're not feeling desirous, or when for some people it may delay ejaculation or cause inability to have an orgasm, or you talked about lubrication earlier. These are serious issues that there are alternatives for, or ways in which they can find strategies that can help. But being able to talk to their prescriber or another professional who's informed is just is essential.
Yeah. Definitely. We should have booked a 2-hour episode for this because I want to go into all of that. And you mentioned earlier, the topic of social justice within this space as well, that super appreciated how you introduced that in the presentation too. So many things I could just continue to go on with about you. If people do want to, we'll definitely include the link to that article that you mentioned that you wrote. Where else can people find you if they want to follow up on some of your work? If they wanted to book you for other stuff, where are the places that folks can kind of follow your work at?
You can start with my Instagram at Dr. Tom Murray, and then also drtommurray.com, as well as at pathtowellness.com.
Amazing. Well, I so appreciate you being on here. And honestly, it gives me some hope and some courage a little bit to, go against a lot of these things that are just normalized and accepted within this field that need to be questioned, honestly.
Need to be questioned. Absolutely. Because, people want relief, right? They want relief and we don't want to be getting in the way. We don't want to be purveyors of oppression as providers.
Yes, absolutely. Well, I'm sure folks have a lot of things to unpack and a lot of feelings to sit with after listening to this, which is always kind of the point and the goal of my podcast here. So thank you so, so much for your time, for your knowledge, for your personal experiences, for everything that you shared today. Thank you so much.
Thank you, Taylor. Wish you all the best.
All right, that does it for today's episode. Thank you so much for making it all the way through and keeping your ears, your hearts, and your minds open. It would mean so much to me if you could take a second or two after listening to this episode to leave a review on iTunes and let me know what you're enjoying about the show. I love reading, what your favorite episodes are, where you guys listen, and definitely feel free to share this with a friend. I mean, part of how we break down the stigmas around these topics is by talking about them, right? And sharing them with more people. So definitely share the podcast. And again, really wanting to include all of you in this podcast. So if you have questions or you want to share a thought or an experience, please send in a voice memo to ask.letstalkaboutit@gmail.com. And I'm really excited to keep having these conversations and breaking down these stigmas. So thank you all so, so, so much. I hope you have a wonderful rest of your week, and I'll talk to you next time.